Hi, good evening, everyone. Good evening, everyone. So, I welcome you all to Unacademy. So, let us just start with this session. Before that, please do not forget to give this combat, and this is very, very, very important. So, save the date and save the time 20th March 2022, 12 p.m. You have to give this, and we have a lot of exciting prizes for all of you. So, we have subscriptions, we have 1 year subscription, 6 months, 3 months, and then we have a lot of gift cards for you people. So, let us just start with this session. And apart from this, as you all know, that we are now going for a very special, you can say, unlock series. Unlock, so you can use my code and get the subscription at an extended price. One more thing, we are having a lot of new batches which have already started for you. Let us just okay. Comment comment on the injury. Yeah, good evening. Good evening. So comment on the zone of the neck injury shown in this image. Comment on the zone of the neck injury shown in this image. Comment on it. The zone of neck injury shown in the image. Excellent. Excellent. It's a zone 2 injury. Tapendra, very good. Very good. So A is the right answer. A is the right answer. Let us go for the discussion of this question. So when we talk about, so in this golden pearls of surgery, I'm going to discuss this thing. The first topic that I'm going to discuss is a concept of neck injury. When we talk about neck injury, the first thing that we all often ask ourselves is what zone of neck injury is there? What zone is involved? So what are the zones of neck injury? If we talk about the zones of neck, what are they? So students, this is clavicle, then we have sternum, and then we have the clavicle. Then we have the cricoid, and we also have the mandible. So this is how the scenario is. We have sternum, cricoid, mandible. Sternum, cricoid, and mandible. Let us see. From the level of sternum up to the level of cricoid, we have a zone which is known as zone 1. So this is zone 1. From the level of cricoid, oh, hello Prarup, hello, God bless you, Prarup. Yeah. From the level of mandible up to the level of angle of mandible, we have a zone which is known as zone 2. Yeah. And then from the angle of mandible up to the base of the skull, we have a zone which is known as zone 3. Base of skull, we have zone 3. So zone 1, zone 2, zone 3. What is similarity between 1 and 3? Some part of 1 and some part of 3 is surrounded by the bony cage. So if you want to do exploration for the neck and you want to expose the zone 1 or zone 3, you'll have to do mandibulotomy and sternotomy for the 3 and 1 respectively. Now, based upon this assertion, we have a lot of things. One more very important thing that we have to know, that whenever we talk about neck injury, we have to comment whether it's a penetrating or no. So if any neck injury is able to cross the superficial cervical fascia, this is considered as penetrating injury. And when we are talking about this, students, you have to understand the first layer, or you can say the last layer of the superficial cervical fascia is marked by a muscle, and that muscle is known as what? Platysma. So this is very, 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 very important, students, that breach of platysma disqualifies for penetrating neck injury. So if platysma is injured, it's a penetrating neck injury. Why we are so much concerned about neck injury? Because neck has vital structures. Yeah. We have carotids, we have jugulars, we have trachea, we have esophagus. But remember, the most important concern is the vascular trauma. Why? Because if there is a vascular trauma, patient will succumb in front of you in minutes. So whenever we talk about the neck injury and its management, the first thing that we are going to ask ourselves is whether the patient is stable or unstable. there could be a possibility that the patient is unstable, or there could be a possibility that the patient is stable. Now remember, if the patient is unstable, what to do? Now you want to go for surgery, but beware, you have to do a sternotomy for 1 and mandibulotomy for 3 if you want to explore them. So thus you have to ask yourself what zone of injury it is. What zone it is. Because if it is zone 2, one single incision, you are into the deep cervical fascia. So zone 2 injuries you manage directly with what? Surgery. So surgical exploration. Now if you have zone 1 and 3, before you go for the tedious process or cumbersome process of sternotomy or mandibulotomy, let us try to seal this injury by coiling or maybe by passing a gel foam. So what is that? So for 1 and 3, the first line management is angioembolization. Angioembolization. And once this angioembolization is successful, it's done. But if the angioembolization fails, then you have no option other than going for surgical exploration. Are you getting this? Surgical exploration. Students, on the other hand, if the patient is hemodynamically stable, that doesn't rule out that there is no injury. Neither does it confirm that there is no injury. So you need to go smartly for diagnostic evaluation, and hence you go for CT. But conventional CT is inferior in evaluation of the vascular arcade, so we add angiography. So CT angiography is what we do. And now one student will say, sir, here you are not prioritizing the zones, and that is why this zone irrespective approach is known as no zone approach. So we have a name, no zone approach. Students, so no zone approach is used for, answer is CT, is used for stable neck injury. So you go for CT angiography, and then you'll check whether there is injury or no. Either yes, there is injury, or no, there is no injury. If there is no injury, observation. If yes, then you will first go for embolization. If it fails, you go for surgical exploration. So this is very simple concept of neck injury. So let us go to next question. One more question. Let us see. Chalo, answer me this question. All except are true for the following condition. So we have a lot of wounds and surgical site infection involved in this question. By means of this, I am going to discuss the surgical site infection and wounds. Tell me. B. All except are true. Anyone more? Okay. Let us see this. Now when we talk about the concept of wounds, you have to understand, whenever you create a wound, now there is a breach. And whenever there is a breach, there is a risk of what? Contamination. There is a simultaneous risk of contamination. Now you all have to understand, when we talk about contamination, it is the immunity. Which will actually prevent the contamination. But this immunity of any kind, be it cellular or be it humoral, it requires minimum 4 hours for activation. 4 hours for activation. And therefore, this is the time during which the wound is at the predisposition and anyone can attack. Thus, therefore, first 4 hours, they are considered to be what? Decisive. Or this is also known as what? Golden period of the wound. Golden period of the wound. I hope this is clear. So the first point that we see here is wrong. Let us see the second point, Southampton score. Bache, when we talk about the scores or the classifications for the, you can say scores or classification for the wounds, what are they? Let us see. When we talk about this, the first that we have is Southampton's. Southampton's has been asked at least 5 to 6 times in your exams. Every time the name is asked, none of the time we have seen a question on the grading. But let us see, Southampton's 1, this is bruise. Southampton's 2 is presence of bruise plus inflammation. That means pain, tenderness, yeah, redness, pruritus. The third is clear discharge. Clear discharge. When we talk about clear discharge, what can be the things here? It can be serous, that is 3A. It can be sanguinous, that is bloody, 3B. Or it can be serosanguinous, serosanguinous. Then we have fourth, purulent discharge. Fourth is purulent discharge. Purulent discharge. Then we have fifth, abscess, or you can say necrotizing fasciitis. Necrotizing fasciitis. This is what? This is Southampton score. We also have a score which is known as asepsis score. When we talk about asepsis score, it is a 0 to 10 or 0 to 5 base scoring system. Yeah. So 0 to 10, 0 to 5. So when we talk about asepsis, I Sumit, I. Any problem? Okay. Asepsis, when we talk about A stands for additional treatment requirement. So additional treatment required. When we talk about additional treatment required, what does this mean? This means in form of what? Antibiotics, broad spectrum. So generally we use the basic antibiotics. You know, now there is a rule. Whenever we use a broader spectrum antibiotics or high-end antibiotics, most of the times we have to justify in the insurance forms that what was the need to use this. Otherwise the claim will not be settled. They will not give that amount. So antibiotics, broad spectrum. The second is we might have antibiotics, or we might also go for incision and drainage, or maybe debridement, in any of these conditions. So A stands for additional treatment required. S stands for serous discharge. You know, the first parameter we have 1 to 10. The other parameters we have 0 to 5. Then E stands for erythema. Then next is P. P stands for purulent discharge. Then S again stands for separation of the skin. You know, whenever there is infection, there will be separation of the skin, gaping out of the skin. So separation of skin. Then again, I stands for isolation of bacteria. And then again one S stands for stay prolonged by more than 14 days. So stay prolonged by more than 14 days. This is what is the concept of asepsis. So the second parameter, Southampton score, yes. The next is, let us talk about the classification of surgical site infection, and this is again very, 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 very important. Let us talk about this SSI. When we talk about SSI, that is surgical site infection, SSI. What are the important things that we have to consider about this SSI? Let us see. What are the important things? SSI can occur along the incision or along the organ where you have operated. So either it can be incisional SSI, or it can be organ SSI. Incision is again divided into two parts: superficial incisional, or deep incisional. If it is superficial incisional, students, we say, what is the criteria? This is SSI along skin and subcutaneous tissues, within 30 days of surgery. Always remember this. The next is, when we talk about deep incisional SSI, deep, this is defined as SSI along incision. So SSI along the incision except skin and subcutaneous tissue. Hi Rachit, hi, how are you? So skin and subcutaneous tissue, that means muscle, fascia, peritoneum, everywhere. Within what? Within 30 days. Within 30 days of surgery, or within a span of what? 1 year in case of implants. So, or within 1 year in case of implants. And this is very, 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 very important. Bache, when we talk about the organ SSI, what is the concept of organ SSI? This is the SSI along anatomy manipulated. So SSI along anatomy manipulated during surgery except incision. So everything except incision, this is covered here within 30 days of surgery, or 1 year in case of implants. Like if I did a cholecystectomy and post-operative day 10, the patient presents with pain and tenderness over the right upper quadrant and the ultrasound shows collection under the right hemidiaphragm. Is this SSI? Yes. Why? Because during surgery the anatomy around the gallbladder and the liver was manipulated. So this confirms. So if you see, superficial SSI can be diagnosed up to 1 month. This is absolutely right. So the answer here is A, always better than D. Is that clear? Many of you must be thinking about D. A is better answer than D. Let us understand one more question. What I've already discussed. Okay. Tell me this question. A 32-year-old female attended OPD for routine evaluation of the breast. Identify the technique of breast evaluation. Tell me. Very good. So when we talk about the techniques of breast examination, this technique is very simple, and this is what is known as vertical stripes. But we have other techniques also where you can go from in to out in a circular way. This is a circular technique. We also have, this is a vertical stripes, top to down, down to bottom, top to down, down to bottom. Yeah. Then there is one more very famous technique. So just try to see, we divide the breast into a dial of a clock. So 12, 9, 6, 3, 1, 2, 4, 5, 7, 8, 10, 11. And then we are moving from out to in. What is this technique known as? Today, actually now, because of Holi, I don't think that patients are turning up for any elective surgery. Emergency I have not done, but yeah, today I have admitted, I'm getting a patient, today I have confirmed a patient of parathyroid. So I will be doing a parathyroid adenoma for that patient. So parathyroidectomy. So that patient will be coming to me after, you can say, Holi. Because of Holi, lot of patients don't want to get operated. It's the festival season. That is why. Otherwise, routine cases, lap chole, lap appendix, yeah, we do. No special case. But parathyroidectomy, I'm going to record and show it to you. And today I've admitted a patient of thoracic outlet syndrome with also features suggestive of Paget's scrotter because the patient was having effort thrombosis, effort related, you can say, fatigue. I'm planning to record that case day after tomorrow, and I'll show all of you how the things are, and I'll discuss that case with the topic of thoracic outlet syndrome (TOS) or thoracic outlet obstruction. So when I'm discussing the techniques of breast examination, what is my purpose? So I'm going to talk about the breast screening. So when we talk about breast screening, let us talk about this. So whenever we get a question, I have decided that the patient is also very close and known to me, so वो कहीं नहीं जाने वाला. But actually the patient, देखो, there is one moral obligation to relieve the pain also. Today the patient was in severe pain, so I decided not to do examination etc. because now it will be very difficult. So when we talk about breast screening, the next question should be what group? What group? And when we talk about group, we have a high risk group, and we have normal risk group. So we have a high risk group and we have a normal risk group. But so when we talk about the high risk group versus normal risk group, the first thing is the age at which you will start the screening. The age of screening, answer is this is 25 or 25th year onwards. And normal risk group, the normal risk group is, this is 45-year onwards. Earlier it was 40-year onwards. So from 40-year onwards, the recommendations have now changed itself to what? 45-year onwards. Next is the tool for the screening. For high risk group, you have the most sensitive tool. अभी इसको 25 and 45 कर लो. So not 40, 45. The latest American Thyroid Association guidelines are recommending it at 45, not 40. So high risk group, the tool is MRI. Here also we do screening with a sensitive, but not that. We use what? Mammography. We use mammography, and what mammography do we use? 2-view. So there are a lot of patients who are concerned, sir, why will I expose myself to mammographic radiation? So you should tell that dose of radiation, the radiation dose if we talk about, it's very low and it is 0.1 centigrays. So it's safe. What are the two views that we are talking about? One is CC, that is top to bottom, that is craniocaudal. And the another one is mediolateral oblique. So we have craniocaudal and mediolateral oblique. Let's say if you see the maximum lump observation, the maximum exposure of the breast is seen in MLO. I always remember MLO like maximum lump observation or maximum exposure. Craniocaudal is CC from top to bottom. But then we have the frequency. On what frequency are we going to repeat it? This is again annual. This is also annual. So we do in annual frequency. So this is what is breast screening. Now whenever we get anything suspicious on radiology, we express that in terms of what? BI-RADS. Yeah. Or if we don't get, we express it in terms of BI-RADS. Do you know what is BI-RADS? What is the biggest concern of any surgeon? Answer is to know how close my breast pathology is resembling like a malignancy. Yeah. Similarly, same thing is like if you have a SOL or you have a swelling in the thyroid, you want to know how close this swelling is resembling with what? Malignancy. Because this is the first and the last concern, and that is why we have TIRADS for thyroid, LIRADS for lungs. We have a lot of things. BI-RADS for breast, PI-RADS for prostate. So BI-RADS, breast imaging, reporting and data system. And data system. This is what? BIRATS. By means of BIRATS, I want to know how close my pathology. BIRATS 0 means inconclusive. And when you talk about inconclusive, therefore repeat the test, repeat the radiology or change the radiology this time. Suppose you are not satisfied with mammo, you can go for mammo again, or you can go for MRI or change it to ultrasound maybe if you want. BIRATS 1 is negative, that means nothing is there. BIRATS 2, it is benign. In both these cases, what to do? You have to go for annual follow-up. Annual follow-up. BIRATS 3, we say probably benign. When we say probably benign, what do you mean? Is there any probability of malignancy also? Less than 2% risk. And therefore, you keep a close eye. 6 monthly follow-up. Then we have BIRATS 4. This is suspicious. When we talk about suspicious, we want to know how much suspicion is there. And therefore, 4A, more than 2 up to 10% risk. Very good, Maria. 4B, more than 10 up to 50%. Maria, you have written a surgery vibes. So I see a lot of positivity in you, and God bless you. You will definitely become a very big surgeon one fine day. है ना? Very big surgeon. So I just, by seeing your name, you have written surgery vibes. No, I connect myself to my childhood days when I was like you, and I used to write myself as a surgeon. So when I was doing my MBBS, whenever I used to go to any place, I did not tell that I am a MBBS student. I used to tell I am MBBS first year, MS first year, I am MS second year. I used to tell, even though, because they were ignorant, they were not knowing how a surgery resident looks. It's totally different thing. The confidence changes when you become a surgeon basically. But I used to lie, and that, in order to keep myself, my ego alive, I got that. I love to call myself a surgeon today, and at that time also. So God bless you. You will definitely become a good surgeon and a big surgeon one fine day. So more than 50 up to 95%. That is 4C. By seeing you people, it just got a bit, you can say, nostalgic about myself. Suggestive. 5 is highly suggestive. Achha, what do you mean by suggestive? More than. Okay, Maria, you have already completed FCPS surgery training. You're from which place? So more than 95% risk of malignancy. And what is BIRATS 6? Students, sometimes we are doing imaging for you can say for a condition where already the diagnosis has been made. So that is a separate case. Like suppose you are doing a BCS for malignancy. So before you do, you again get yourself rechecked that is there a single lesion or there are multiple lesions. Are you getting? So in order to confirm on a background already where the diagnosis has been made, this is what is BIRATS 6. I was there, everyone in Pakistan. Give my salam, give my regards to everyone there. I love you all, and there is no India and Pakistan has already been same, always on all the pages except for some political propagandas. Otherwise, it's same. So give my love to everyone there, and ask your friends also to join my classes. So BIRATS 6 is already the biopsy proven. Biopsy proven. Next, very important thing that we have is, we have seen this BIRATS. When I am discussing all these things, I'll also discuss with you the risk prevention in high risk group. What do you mean by high risk group? High risk group means suppose you got a patient who came to you and who said, sir, recently my cousin has been diagnosed with CA breast, and I have a family history where my aunt was diagnosed with carcinoma of the ovary, my maternal grandmother as was diagnosed with CA breast. So don't you think that there is a lineage hierarchy going on? There's a lineage and hierarchy going on, and this is what is a high risk group where you can suspect a BRCA mutation. Yeah, BRCA mutation. Let us try to understand this. Let us try to understand. So risk prevention in high risk group. In high risk group. So when we talk about risk prevention in high risk group, how do we see this? But the first is, she said, doctor, am I at risk? You should be very modest and tell, ma'am, I'm not sure, but you may be suspicious. ऐसा नहीं कि you will call and say, नहीं नहीं तुमको भी होगा, you are also, no, ऐसा नहीं, okay. So she'll say, then sir, how to reduce the risk? You'll say, you can offer her a lot of treatments, among which this is one, prophylactic bilateral mastectomy. The moment you advise this to the patient will get angry. Doctor, I just came for a piece of advice and you said remove the breast, reduce the risk. What kind of doctor you are? She left your chamber. You send your assistant, nahi, madam ko bulao. You call madam. And then madam said, ki, doctor, what did you say? But I don't want to get treated from you. So you'll say, ma'am, I have one more treatment option for you. She'll say, beware doctor if you utter something rubbish. You'll say, ma'am, you can go for prophylactic bilateral mastectomy and also bilateral salpingo-oophorectomy. Why? BRCA has equal risk of what? Mutation, equal of CA breast and CA ovary. So salpingo-oophorectomy can be also offered. So there are a lot of females whom you should advise that, ma'am, you quickly complete your family and get it done. Like Angelina Jolie. Yeah, sandal padegi. So there are a lot of people who have completed their family because life is more important now than the reproductive organs. Yeah, breast you can get reconstructed, so not a problem in the life. But yes, if you carry them, you definitely take a risk. Third is, she says, no, sir, suggest me something other. Then you can suggest active, before that, chemo prevention. Now, what is this concept of chemo prevention? Chemo prevention. Now, what is the drug that you are using here? Chemo prevention. Answer is tamoxifen. Since the lady is young, you cannot use anti-estrogens. So you are using SERMs. So when you are using SERM, this is very, 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 very important. And now the complications will arise. So after 1 week, she comes to your clinic and she says, oh my God, doctor, you have suggested me a drug which actually increases the risk of one cancer. And just see, sir, after I started the drug, this is all reaction I'm having. So, but you should be knowing the most common complication, early complication. Answer is flushing and vasomotor symptoms. So, flushing is the most common. And then, most common long-term complication, CA endometrium. She said, thankful to friend who told me about this. Otherwise, doctor, you would have killed me. I said, who is your friend? He said, I'll not tell. I said, I know Wikipedia. Majority of the patients are what? Wikipedia enriched. I said, didn't your friend tell you about the most dangerous complication? She said, I said, what is? She said, what? So, most dangerous complication is your DVT and pulmonary embolism. Yeah, pulmonary embolism. So, I operated on my great-grandmother, and that too maternal side. Imagine wife and wife's great-grandmother, maternal mother. And imagine what pressure I would be having. So I operated on her and I did a mastectomy MRM for her for CA breast. She was 72 years that time. And then what happened? We started tamoxifen for her. I told her not to be immobilized for a long time, but she didn't take heed to that. And do you know what happened? One fine day she developed DVT. And I've lost her because of pulmonary embolism. So this is again a real life scenario. This happens. Yeah, this happens. So tamoxifen is associated with coagulative disorders. So one student said then, sir, why aren't you using raloxifene? So tamoxifen versus raloxifene. When raloxifene is better than tamoxifen, why aren't you using? There was a trial which was known as STAR trial. side effect of tamoxifen and raloxifene, and it clearly concluded something I'll tell you. So why you want to give them tamoxifen? You want to reduce the risk of invasive cancer. Invasive cancer, the risk was reduced in raloxifene as well as tamoxifen. But non-invasive cancers, particularly what? In situ tumors. So non-invasive cancers or non-invasive tumors, yeah, they were not increased, they were reduced by tamoxifen, but they were not increased. Rather, it was seen that there might be an added risk. However, this added risk was a biased study. You are not actually reducing the risk. That is why you are seeing an comparably there is a higher incidence. Or koi baat nahi. So that is the reason, even though raloxifene is safer, we don't use raloxifene. He said, no, doctor, please don't get me puzzled. Tell me something which is safest. I said, ma'am, then you will have to take active participation in your own treatment, and that is what is known as active surveillance. You and me both will keep an eye over the tumor. And what is the concept of active surveillance? What is that concept of active surveillance? Let us see. This is very, 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 very important. Self-breast examination. Self-breast examination. I've already told you the techniques, and this is to be started 18 to 20 years onward. 18 to 20 years onward, and that too on what frequency? Annual frequency. Monthly frequency. So we'll tell her about the 3 examination techniques. Whatever is safe, whatever is convenient, she can do monthly. Then she said, when will I have to visit for clinical breast examination? So clinical breast examination is done by the consultant, and this is started what? 25-year onwards. So 25-year onwards, she'll be visiting your clinic or hospital for this, and this is done 6 monthly, so biannually. She said, sir, won't you add something for screening in terms of radiology? So I said, yes, we'll do screening. So screening, and we'll do screening MRI, and also since there is an equally increased risk of what? CA ovary, I will also do CA125. So CA125 and CA1 and MRI, this is to be done 25 years onwards, and that too on annual frequency. So this is all about the active surveillance. Students, this is all about today, and this is all for the class. I hope you enjoyed, and first of all, happy Holi to all. So do enjoy, do celebrate this festival, and do join me on Unacademy. Do follow me on Unacademy so that you don't miss notification of my classes. Do share the links of the class with your friends also. You can join Unacademy using the code Surgery Live, or you can use Dr. Dixit. Download the app and subscribe to the special courses and plus courses. Do recommend Unacademy to your friends also. Till then, bye bye.